And we are live. Thank you guys for joining in today. I am LaSharday Scott, the CEO and president for Scott Center for Observation and Treatment and Transition. And today I have the privilege and the honor of having Dr. Erin Marten. We are going to talk about equitable health. But before we get into that, she is a doctoral prepared certified nurse, midwife, providing full scope, obstetric, and genealogy. I can't get the words out. Gynecologic care in Toledo. Excuse me, I apologize about that. After falling in love with her midwife model of care, she made a career and changed in 2007 and began attending nursing school to become a midwife. She graduated from Frontier Nursing University with a doctor of nursing practice with a specialty in nurse midwifery. In 2016, she is proud to also hold a master's in public health, focusing on maternal and child health, a certificate in human sexuality from the University of Minnesota. Dr. established Solace Health and Wellness, a sexual and reproductive health, wellness, and justice organization in 2020 as a direct response to the increasingly disparate health outcomes experienced by Black women, LGBTQ individuals, immigrants, and refugee seeking peoples, and other marginalized and oppressed communities to continue the experience harm within within our healthcare system. She's committed to being an active participant in changing landscape of sexual reproductive health care and to push health equity for all people. Thank you for coming. Such an extensive bio.
It just means I like to talk a lot.
It is okay. I am happy that you came on today. I am looking forward for our audience. So this is not an interview, it's more of a conversation. Some of the things that are going on, especially in the Toledo area, that people may not be privy to. So basically it's just going to be two friends having a conversation and just spreading some awareness on some things that people should be, mindful of what's going on in our community.
Yeah, great.
So let's just dive into it. So we know why you started, or we know that you took a change in your field. What kind of brought on that change? Like what was the main?
You mean from when I started midwifery or from when I jumped off to the nonprofit space?
Both. Tell us how you got this. Yes, tell us how you got here.
Well, see, I fell in love with midwifery, probably in the mid 2000s. And I haven't talked about this part of my story for so long since there's so much that's happened in the meantime. But, I grew up in a big family and I was the oldest of 5. And so it kind of seemed like my mom was always pregnant, at least for like the first 10 years of my life. And she was always, she always breastfed as well. And so when I learned about midwifery, it really just kind of made sense to me. And so I dove right in. I was not in healthcare at all, but I just jumped right in, decided that I was going to become a nurse with the sole intention of being a midwife. So went to nursing school here in Toledo at Lourdes University. And then started working on the floor as a nurse once I got that certification, which I loved. But midwifery was always the goal. And so I, never wavered from that goal. And I really love it. I feel like it's a typical story that a lot of people kind of fall in love with. Well, I always say that you don't become a midwife by accident, right? It's not something that you just kind of fall into. It's a passion, it's a calling. And I think that a lot of people start out in midwifery because we all think, know that, like, witnessing the birth of a baby, the birth of a mother, the birth of a family is, just an astounding miracle. It never ever gets old. But as I got further into it, I started just really falling in love with I guess I just say kind of keeping women healthy. I really look at women or women identified people as kind of the cornerstones of our society. And when we keep women healthy, when we approach the health of women as kind of a holistic, what beyond, the labor and delivery room or beyond the exam room, I think we're really kind of, doing a service to our society as a whole. And so I just really fell in love with all of the aspects of obstetrics and gynecology and midwifery, and just women's health, sexual and reproductive health, just kind of in general. But as is mentioned in my bio, as I was working as a midwife and taking care of families and people in the Toledo area, I started learning about what's behind healthcare and what's behind the health in our communities, kind of what drives the health in our communities. I always say that I have always had a public health heart, so it seemed really natural. And I really do feel like earning a master's in public health in maternal and child health has like rounded out my education, because I have a really strong background in the actual delivery of healthcare, but there's so much more to it. And public health really, to me, public health is everything. And I started learning about the disparities that exist in sexual and reproductive health and women's health, and really kind of started seeing the forest for the trees, and that the disparities that are experienced today are not an accident, that it is exactly how things have been designed, and learning about how, such a big tangled web it has all become. And I just really am so passionate about helping to find our way out of this kind of mess that we've gotten ourselves into. Obviously, it's much easier said than just saying that we want to all fix this mess. Of course, we all want to fix the mess, but and so ever since then, I've really just kind of jumped in. I started Solace, kind of like I said, as a response to that. It's just kind of my way of utilizing all of the education and the experience that I've had so far and kind of just approaching it in a different way, a way that to me makes so much more sense, because it's person focused, it's family focused. And it, we really strive to kind of restore a sense of dignity to the way that we help and work with people in their overall health. So that's how I got here. Long story short, huh?
No, that's fine. So I guess for me, one, I wish when I was having my children, I knew all of the options to obtain a midwife. I never even knew that that was a thing that I could personally have. Mm-hmm. So people that are watching the call or this talk, what are some of the steps, or could you provide some of the steps to how they're able to obtain a midwife during their pregnancy?
Yeah, absolutely. So just a little bit of background as kind of the way that midwifery works in the United States is that we have a couple of different classifications of midwives. So we have nurse midwives, which is what I am. And so I obtained, like I said, a nursing education and then went on to obtain a graduate degree. So I'm technically an advanced practice nurse. So kind of on the same level as like nurse practitioners. And so primarily, of course, nurse midwives work in a hospital setting. So employed by a hospital where they would see patients kind of in an outpatient clinic setting, and then be available inpatient at the hospital to, guide the delivery. The other classification, the other main classification in the United States is certified professional midwives. So professional midwives obtain their education largely kind of apprentice based. So they there is, and I think it's a kind of a misunderstanding of professional midwives, but there is a large amount of education that they do go through. And then there is a standardized kind of process for them to take to get to that, but they do not have that nursing background. So that would be kind of the main difference. And so they obtain their education, and then they get, do a certain number of hours of learning in a practical setting with kind of an elder midwife. And then they take a standardized test, and then they practice primarily in the home birth or birth center setting. The key about that, though, or kind of the big, I don't want to say the issue about that, is that the laws that guide professional midwives and nurse midwives is different from state to state. So there are some states where certified nurse midwives can practice independently, can open your own practice, kind of, be run only by, midwives if you want. In Ohio, we have to practice with a collaborating physician. So we always have to have some sort of touchstone with the physician who will review our charts. In my situation as a midwife here in Toledo, we do deliver in the hospital, and there is always a physician on call in the hospital. So midwives don't do surgery. So if for some reason one of our patients was progressing towards, and things were looking like a C-section might be the outcome, they are there in the hospital with us at all times to do that with us. The professional midwives who work in the home or in a birth center setting, there are some states where they can practice, they can start their own practices. In Michigan, they collaborate beautifully with the nurse midwives and the physicians at the University of Michigan. It's really a beautiful setup that they have there. In Ohio, certified professional midwives are not recognized as medical providers at all. So they don't have a license. They have their certification, but they don't have any sort of license. They can't accept insurance. In a lot of cases, they have difficulty ordering lab work, ultrasounds, and stuff like that. There are both in Northwest Ohio where we are. And so you can access those. The midwives that I work with, actually I have a couple different settings that I work in, but we accept all insurances, so Medicaid, private payer insurances as well. And then also at the FQHC that I work at part-time, those midwives can see patients on a sliding scale fee, Medicaid patients. So anybody should have access to a midwife. I think the problem is that sometimes people don't really know where to look. But we're out there. We're definitely out there.
So I heard you mention the insurance. So excuse me. So the insurance covers the cost for the midwife. Is that what I'm hearing?
Yes. Yeah. So with most insurances, they cover the pregnancy as a whole. So your prenatal care, your delivery, and your postpartum period is covered as like a certain amount of time. And we are covered under most, if not all, insurances. Of course, that depends on like the system that you work in and what insurances they, or accept as a system. But yeah, we're covered under insurance. We can bill just like any other providers. Yeah.
Okay. So I know that there's, and you probably know these statistics a little bit better than I do. So we know that, especially here in Ohio, that infant mortality is a huge thing. So knowing that Black babies are more prone to not reach the age of 1 compared to children that are not of color, what are the true benefits of having a midwife? And not that one is deemed more than the other, but what are some of the benefits of having a midwife during your pregnancy?
Yeah. So, of course I'm very biased, but I think that, and honestly, this is also, this, bears out in evidence as well, that, for mothers who are low risk, And then for their infants, the care of a midwife is, we see a lot better outcomes in those situations. I think the difference in what midwives offer, and, obviously there needs to be both, right? We need physicians, we need midwives. We can only practice to a certain level. Like I said earlier, we can't do surgeries. We can't manage, very high risk types of pregnancies. And so there's definitely room for both. And I truly do think that a lot of work needs to be done to kind of maintain that relationship between physicians and midwives. But I think, we call it the midwifery model of care. So it is a different model of care than the medical model of care. Typically with a midwife, even in the hospital and then especially out of the hospital, you will see longer visit times. You will see a lot more patient education happening. You'll see a lot more effort put towards creating those relationships with the patient and then the family unit that patient kind of comes with. There's a huge awareness towards mental health. And then a huge piece of the outcomes for both mom and babies is what happens in the postpartum period. The postpartum, talking earlier about insurance, and it is really kind of a travesty in our country where postpartum insurance coverage ends at 6 weeks. There's a lot of effort to change that. And I actually think that a newest piece of legislation in Ohio is asking for that Medicaid coverage, I think up to a year afterwards, which would be so beneficial because complications do happen after 6 weeks. And, for both mom and baby. But up in that 6 weeks, you will find midwives seeing patients more than in the medical model. We will typically see a patient at 2 weeks and then at 6 weeks postpartum. More often, if they had a complication like high blood pressure, if they had a C-section, we'll check on that C-section incision. So I think, that piece is really huge. So yeah, I mean, there's definitely a lot of benefits. And I think really what the benefit is that kind of interpersonal benefit, getting to know the family and seeing them as, a unit of people who are entitled and deserving of that really kind of that one-on-one care where we really get to know them, know what's going on in their lives. So.
Absolutely. I think that's a huge component in just having an overall, comprehensive care all the way around, and that you're feeling heard. I know here within my organization, we're always preaching to the clients, like, you have the right to interview who's taking care of your health needs. I think people get this mindset that, oh, they're a doctor, it must be right. And I'm not here to bash any medical professional, but I say that to say that we do have rights to ask questions and to have a level of understanding of what it is that they're telling us,
Yeah, absolutely.
Because I think sometimes medical professionals, they have their own terminology, and when you're explaining things to the patient, it goes over their head. And you're like, what are they talking about?
Yes, yeah. Yeah, I always tell people that you are the consumer. You are the one that's paying for this care.
Yeah.
Obviously, it's a little bit more complicated than that, but we work for you. And absolutely, if you are not vibing with somebody, if you are not appreciating the way that they're speaking to you, or if you are feeling like you're not getting good quality care, again, I know that this is like way more complex than just saying like fire your doctor and go find another one, because of course people are, limited by insurance and stuff like that. But yeah, I mean, I guess in an ideal world, that kind of consumer idea would be much more, kind of realized by people, like, I work for you, you're hiring me, but there's a lot to that as well.
Yes. So, I know you said that you work with the LGBTQ community.
Yeah.
Tell us some things about that. Like, what does that look like, or what services are you providing for that particular community?
Yeah. So, so before I get into that, so Solace is, we don't provide health care services. So we say we provide health services. I would love to provide, I would have loved to like open my own clinic. And I always say if somebody gave me like $4 million to open a birth center, I would do it like that day. But as I mentioned earlier, there's, I always have to have a collaborating physician. So it's not like I can just go open a practice. But so what we kind of focus on is utilizing education, advocacy, and outreach to fill in the gaps that people may be experiencing from the health, like kind of the larger healthcare system. So we offer a lot of like different kinds of educational opportunities. We have childbirth classes, breastfeeding classes, and drop-in clinics. We have support groups. I have lovely young women who teach yoga and do like the sound baths and offer those types of things, to kind of, bring up the wellness side of things. We have, weekend workshops that people will hold. We have a yearly wellness retreat. So that's kind of the services that we provide in general. And then I always say that our kind of target population that we're trying to reach is medically vulnerable communities, which you mentioned in my bio, and, kind of the biggest communities that are experiencing, or that I would consider medically vulnerable, are Black women, LGBTQ individuals, or the LGBTQ community. And then people, immigrants and refugee seeking people who just don't have access to care just at all. In the LGBTQ community, one of the things that we're seeing is that in a large percent, they're not seeking care at all, because they, depending on kind of, particularly for trans and non-binary individuals who, we would consider gender expansive, they have, we've collected so many stories of people's experiences where, they'll go in for an ear infection or an earache, and they'll end up with STD testing or an HIV test because the doctor presumes that, they're high risk, that they engage in high risk sexual behavior just simply because they identify as gay or lesbian or whatever. We have, people who are reporting experiencing medical exams that are not necessary because the doctor is curious about what, their genitalia may look like, or, may be curious about, how their body is changing under hormones. Or there's so many stories where people, and then, just even the basic like communication where, and God, I hate to say this, but it's so rampant where, providers, and I have to put midwives and other nurse practitioners and physician's assistants in this category as well. But, with a lack of understanding of how to honor people's chosen gender, or the gender they identify, or the name that they've chosen to go by, or the pronouns that they choose to go by, that people are just constantly being misgendered and dead named. And so people just largely have stopped seeking care. So there's a huge percentage of our communities who are not getting health care at all because they're afraid. For LGBTQ youth, We know that rates of suicidality are much higher. Rates of homelessness are much higher because many have been, kicked out of their homes. Rates of hunger. There's, higher rates of I said homelessness, but so these are all affecting people's health. So what we do is very simple. Just provide a space for people to go where they feel celebrated and honored for exactly who they are in that moment. We provide support groups for LGBTQ teens, which to me is something that's so important, particularly with the number of teens who are not accepted in their homes. And then we also have support groups for LGBTQ adults. And then we have support groups for parents of LGBTQ teens to get together and kind of talk about the things that parents find important, like the safety of our babies and what is the dating world going to be like for them and all of those different kinds of things. So it's really very simple. It's just, like I said, providing a space for people to go where they feel loved and celebrated for who they are.
I think, well, you touched on so many things, so I'm gonna have to retract that.
Yeah.
So, first, I was going to ask you, what was the age group that you guys service? So I heard teens. So what does teens start with you guys?
So
14,
I usually say about 12 to 17, but most of the kids who come to those groups are about 13, 14, 12, 13, 14. I think when they start getting older and they start driving and they have kind of a different kind of group of friends where they can kind of go where they want and do what they want, they're not so interested in hanging out with us anymore. So it's usually younger teens that we have, but so like middle school and like early high school. But they are absolutely amazing. I love them so much. These kids, they give me life.
So then you mentioned some things that I typically advocate for my population that I serve here at Scott. We were talking about medical biases. Basically, that's what I'm hearing speaking on.
Yep.
I always say that we really have to, when I say we, the medical field really needs to implement a lot of like cultural central trainings or implicit bias trainings, things of that sort, to make us better. Because who are we to pass judgment on anybody? Like, nobody's perfect. And who said that one way is to live better than the other? You get what I mean? Well, people should have the right to choose whatever it is that they choose. Your job as a medical professional is to treat whatever it is that they're going through, and not pass judgment or not have your own biases. And I know in some cases we all have experienced our own biases, but when it impacts the health or the life of one, that is not the goal. That is not what we should be doing, right?
Yeah, absolutely.
So I'm wondering, I'm not sure if you guys do that. So do you host anything? I know I typically go in and do trainings or education pieces around what it is that my patients are experiencing and why you're stigmatizing them and these misconceptions you guys have. So I go in and providing those trainings to the hospitals and things like that. Have you guys done that at Solace?
Yes, in a couple of different ways. So I have sat on, obviously, like a number of panels, usually with the local colleges, to kind of talk to college students, which I think is really important because these are the next generation of healthcare professionals. And this is one of my big kind of soapboxes. But, I think it goes deeper than just getting into these classes and talking to people. I think in order to be like intentionally, truly working on your own biases and how those come out of you, like it's a constant job. I have to work on it all the time, and I am deeply invested into working with marginalized communities. And So it's not just like you take a class, you check a box, and then you've got your implicit bias training done. It takes a really significant level of like interrogating your own biases all the time. And a really, really deep level of humility to understand that you're gonna make mistakes. We're all gonna make mistakes. Those biases are gonna slide through because they're so deeply ingrained in how we were raised and where we come from. But the humility comes from the acknowledgement and then move on. We've got work to do. But when you look at college students now, on one hand, I'm so hopeful because it's going to take a while, but these kids these days, they are on it. They know, like they've been raised in a world of anti-racism and, you know, gender and sexuality, fluidity, and all. I mean, they know the things by the time they're like 10 or even before, they're already on top of these things. So I am very hopeful. But with this in our system, you have to look at the kids who are getting to nursing and medical school in the first place, where they're come from, how they got there. And, you know, especially with these kind of newer regulations or the recent Supreme Court ruling with affirmative action, I honestly sometimes don't know. Oh, I guess I just really hope that this next generation coming up is equipped to do that self-interrogation in the way that it needs to be done. So I mean, we have to go even back further. And of course, then it's, you know, how are we raising our young kids? What are we teaching our young kids? Like, what does it truly mean for them to experience diversity in their life? And so it goes way, way, way back. In the meantime, obviously, we're going to keep doing what we're doing, right? We're going to keep going into classrooms and talking, and we're going to keep going into hospitals and talking. But, you know, when I was in nursing school, it was like, we called it cultural competence at the time. And I think now it's called like cultural humility. But it was like a few paragraphs in a book. And it was like, you have a person from X country come in and they have these customs. What do you do? You know, and it was like not at all critical thinking. And I don't even think that I had much more training as, you know, in a graduate setting than that. So that has to be better. To answer your question, though, we work really closely with an organization called the Northwest Ohio LGBTQ Coalition. And that is a collection of professionals and I guess civilians, for lack of a better word, of people in this area who really kind of want to come together to kind of create change for the LGBTQ community, which is an extremely intersectional community. And so what we're working on is creating a credentialing program for area mental health and direct healthcare providers, where we go into their offices and we evaluate everything from, is there visual representation of queer families or queer families of color, or are people seeing themselves represented on the walls or on your bulletins or whatever? And is your staff trained to use appropriate pronouns or the pronouns people have, you know, asked to be called by? To, you know, what is the, you know, how streamlined is that process? Do we honor life partners as somebody who can have medical information? And then to, you know, even the nuances of caring for maybe somebody who's medically transitioning, because there are differences. And every major medical college, so like pediatrics, endocrinologists, family practice, all of them have an update. This is our stance on caring for the LGBTQ community. This is what we expect you to do, even if not everybody kind of follows that. So we go into their offices and we evaluate kind of where they're falling short. And then we provide them that training to bring everybody up to speed. And then when when we are satisfied that they've done what they should be doing, then we list them in a directory that area LGBTQ individuals can access. So that way they know that when they're going to get medical care or mental health care, that they are somewhere that's going to be safe for them, safe and affirming. So that's a huge program that we're working on, and it'll be the first of its kind in this area. And we actually have support from the city of Toledo to do that. So that's really super exciting.
Yeah, that sounds exciting. And then who knows, that could be the model for a lot of different things that's going on in this particular community, and maybe other states pick up on it. So I think that's awesome. I kind of wanted to go back. So you said representation matters. It does, especially in brown communities.
Yes.
You had mentioned, and I hope I'm not misconstruing your words, but you had mentioned something along the lines of this generation that's coming up, what that may look like. So this is why I'm reiterating representation. Sometimes specifically in Black and brown communities, if it's not seen, sometimes they don't think that it's obtainable, right? So I think us being in these positions, I know you have a great team of people over there at Solace. I know you said you're in the schools. I think if we're able to come to like career day or all these things, just to kind of let the children know what other jobs are out there, because we hear the same ones. You can be a police officer, a teacher, the basic ones, and not to call it basic, but the main ones that we always hear, the mainstream ones, right? And then people look at social workers and they always say, "Oh, you're going to take my kids," and it's like, no, we do more than that in social work. It's a lot more. You can work with, the aging population, or what it is that I'm doing. I'm working with mental health and sickle cell, and I'm doing all these other areas. I just think representation is huge in every component of our life, whether it's educational standpoints, going to doctors that look like us, because we know that we get better outcomes that way. There's just a lot that's a tribute to how we see the world, because my lens is different than yours because of backgrounds, but we want to make sure that we are incorporating and making people feel that word that you said, safe, regardless of where you come from. But that would be in an ideal world. I know things are, sometimes I feel like some things are constantly repeating itself, or like we're taking more steps back than we are moving forward. But I don't get discouraged by that. That just pushes me to advocate harder and find other ways.
Yeah, absolutely. I think that was just kind of, obviously I agree with everything that you said and have formulated a lot of thoughts kind of like you did before. But yeah, in my world, specifically in like healthcare, and then more specifically in like obstetrics and gynecology and midwifery, there definitely has been a big push to diversify the workforce, where there are now scholarships available for people of color and Black people, and people who have otherwise been minoritized for whatever reason. I obviously think that is wonderful and a step in the right direction. I think when it comes to DEI type initiatives, I think we have to be careful, because just like everything kind of becomes like a big buzzword, DEI has become such a big buzzword, right? And so all of these companies are like, DEI initiative this and DEI initiative that, when really in reality, they're still just checking a box so that it can look good. And I think that while it is really great to bring people of color and Black people to the table, I think what people miss is to make sure that they're safe when they get there. You can't bring one Black person into a room full of white executives and then
They call it
have them answer for the whole community or do all of the work for the whole community. And I feel like it's the same, because so like in healthcare, we have residencies, right? Where a group of new doctors starts every year and they go through training. And it's very apparent when you have that one person who is there to fill that checkbox and to be the representative for the entire race or the entire culture. And I just can't imagine that that's a good, comfortable, safe feeling for them. So I'll say all of this to say, I don't know the answer. I don't know how to make that better, other than, working to eliminate barriers. I have a wonderful friend who you should totally have on your podcast or on your on your little video cast here, who does these kinds of trainings in hospitals and has taught me so much about the barriers that marginalized individuals are up against, and that those are present from birth. So I don't know the answer, and I don't think anybody knows the answer. It really goes back to kind of what we said in the beginning, that like this whole big system is working how it's supposed to, how it was intended to at the beginning. So it's a big battle. But I definitely think that we should see ourselves reflected in our healthcare providers and in the people in the community who are doing this type of work, for sure.
Yes. So you spoke on, that was a heavy it's funny because I have my own personal opinions about the DEI personally, but I'm not opposed to it, but I feel that we need to be more intentional.
Yes.
Black people have been trying to have a seat at the table from beginning of time. Let's just start there. More importantly, when we get there, as you stated, I am not the voice for all black folks or people of color. We need to bring in more people of color. So we speak of DEI. It should not just be one, as you stated. It's all these other individuals, and then you have one black person speaking for the majority. That's not fair to that individual. So there should be teams made intentionally. So you bring in people from all different backgrounds to bridge that gap in regards to what's going on in these communities, because I know there's individuals that identify as Black at your organization may feel totally different than how I feel about a situation. So it's really, it's just staying intentional and making sure that we're not missing any marks by just making one person the go-to, right? That is my biggest piece with the DEI. Personally, I cannot see myself paying for a training that I've been born into. Like, I'm from Detroit, Michigan. I've been in, you know what I mean? Like, I've lived this. There's no training that can teach me about me.
And if you're gonna bring a DEI consultant into your company, make it a Black person's DEI company. You know what I mean? Not mine. Don't hire me. Hire somebody. You know what I mean?
Absolutely. So we just have to be more intentional. I think that is the start, and that is the key, and making sure that as you said, it's a new buzzword because everybody's talking. I mean, it came out of nowhere for me. I said, well, where did all this come from? I see all these positions hiring, and it almost makes me feel like that affirmative action type thing. We're just trying to meet a quota. That's my personal opinion. It may not be the case, but that is how I feel. I do not believe in watering down something that is so needed within any organizational structure. So when you talk about systems, the system should be easy enough for individuals, regardless of race, to navigate and receive services, whatever it is. There should not. The United States, we suck at that. You go to other countries, or they have their medical systems down pat. Like, they don't even have to worry about fees, especially in Canada, Cuba. All these places, they have free medical services. that should not be a barrier for people to have the overall quality of life. But yet people won't even go because they don't want the bill.
Yeah.
That is insane. That is insane.
Totally insane. Yes, absolutely. I agree 100%. Yeah.
But like I said, I try to be as authentic on these talks because
Yeah.
if I'm thinking it, somebody else is thinking. They probably have even deeper feelings
Yeah.
about certain things than I do.
Yes. Yes.
But I definitely feel if we're getting up every day going to work, we're paying taxes, all these things. It's like I can't get the basic, or I have to jump through hurdles to get the basic necessities. I
Mhm.
mean, even with my own children, I've had to jump through hurdles to get certain prescriptions paid for. And it's like they were born
Yeah.
with these diagnoses. They
Yeah,
didn't
and they're
act.
like life-saving medication where it's like my niece has a severe rare form of epilepsy, and the number of times my sister's called me crying because she can't get her epilepsy medications. She's like, she needs this to live. Why can I not pick it up? I picked it up last month. I can't pick it up today. What is going on? It's absolutely insane. Waiting for a doctor, a prior auth, or why do insurance companies get to decide if my niece's epilepsy medication if she needs it? It's absolutely insane.
It's funny you said that. I actually sat on a call with a bunch of medical insurance companies, and I told them my personal story because I said, if I'm dealing with this, hearing you talk about your niece, why is it going to take for them to die for
Mhm.
you guys to, like, and then more importantly, we know even with legislation and all those things do not get passed through unless people are personally impacted.
Right.
I mean, I look at some of the things that went through with the president. You're pushing certain initiatives because you are personally impacted by it. So how do
Mhm.
you feel? And I know we can't save the entire world in one day. I understand that. But who determines what gets more hierarchy than the other?
Right.
It's
Yeah,
personal
that's
preference.
yeah, that's why it's important, another huge like kind of level in kind of the advocacy work. I think that, that I do as a reproductive justice person, and I'm sure that you do in your causes of sickle cell and mental health, is advocacy at the political level. And I know that not everybody loves politics and that not everybody's cut out for politics, but like telling your story is so important. And
Yes.
I think it seems, I mean, it's hard because it always seems like it's not making any sort of impact. And it's hard to get up there and tell your story. I mean, that's so traumatizing. And then, kind of kicking it back to the LGBTQ, there's so many of these bills going on right now that are affecting young LGBTQ people. And if like a key way to get this stuff changed is for those people to go to governments and advocate, but yet they're like minors, and it's like re-traumatizing them every time they have to talk about how they were kicked out of their house, or whatever it is. It's like it's just crazy. Like it makes me uncomfortable. I do not like putting children in that position, and I don't like seeing them in that position. I don't like seeing anybody in that position, but like telling your story is so important because I guess you just never know when it's just gonna kind of impact that like one person.
Yeah.
Because you're right. What it really takes is like one legislator or two legislators or whatever to take on your cause. That's the only way we can get anything changed.
Yep.
And there's so many causes that are so important to so many people.
Yeah.
It's hard. It's hard.
Yep. Yep. But I'm gonna say this, and I'm like I told you, I'm very authentic. We know race plays a huge role in how things are,
Mhm.
how they're voted on. So
Mhm.
even with in my area, of expertise, we know patients are disproportionate at high numbers. We're talking about over 100,000 Americans living with this chronic diagnosis.
Mhm.
Cystic fibrosis has 30,000 Americans and they have all of the funding.
Mhm.
Why? Because more whites, more blacks are impacted by sickle cell disease, but
Mhm.
predominantly white and cystic fibrosis.
Mhm. Yep. 100%.
So who
100%. And the same with like maternal, in my world, that's the maternal mortality rate. Like that is like racism is the reason that the maternal mortality rate is what it is. So it's, yeah,
yeah.
I
So
agree.
I want to ask you this, because it's been on my mind. I just want to circle back. So I noticed that you opened up your organization during COVID 2020.
Yeah.
That is amazing because people were not there mental, like we were stuck at home. We were in the house.
Yeah.
So hearing that you started this organization in 2020, what is your goal by 2025? Because that will be your 5-year mark.
Mhm.
What see by 2025 with your organization?
Wow. So I guess there's a couple, I mean, like on the kind of practical side, I would like to be fully funded and, to have kind of those sustainable funds because as you know, that is the struggle. It is
Okay.
it's insane to me that nonprofit organizations have to work so hard for funding, and we're out here, we're the people out here trying to do the good work. And we have to like claw our ways, to these levels of funding that other places just get. So my wow. So my goal is to, and I'll tell you, like truly, my goal with the organization is, it was, my world is maternal health or women's health. So that was the call that I was trying to answer. What can I do? How can I impact, even just locally? How can I help women in this area have what they need to navigate the healthcare system better? And God, I've had this conversation so many times, and I've definitely been called out for a lot of like kind of the ideas that I have. But to me, this kind of goes back to like, the system is working in the way it was intended to. I think it's so important for us to have more education about how our bodies work, how pregnancy works, how motherhood works, how parenting works. And obviously it's much more nuanced than that, but you know, I see people daily in an exam room who have never been taught, have no idea how their menstrual cycle works, how to take care of their body, what their body is telling them, what is normal, what is not normal. I use this as example all the time, but I talk to people all the time about fibroids. People are having really heavy menstrual cycles and their iron is low and they're sick. And I ask if anybody in their family has ever had a hysterectomy or have a history of fibroids. And we don't talk about that in our family. I don't know the answer to that. And it's another, I guess, kind of like cause or issue of mine is to just kind of increase the level of sex education we have. And when I say sex education, I'm not talking about man and a woman give each other a special hug type of stuff. I'm talking about
Yeah.
like what's happening in our body. And so but also like going into an exam room, how do you advocate for yourself? How do you talk to your provider? How do you recognize when you're being mistreated or coerced, or if they're recommending something that is for their convenience and not yours, or because they think you're too stupid to know what it is that you're talking about? And it's about self-advocacy, self-efficacy, all of those, things we talk about in public health. And yes, it is not the victim's job to fix the system, but like we're in like an emergency state right now with maternal mortality, with the number of Black women who are dying every year in relation to childbirth, or pregnancy and childbirth. We cannot wait for the system to catch up, right? So that was my goal in starting the whole organization in the first place, was to figure out some way to educate women, to help women learn how to advocate for themselves and for their families in this big, bad, scary system we have that's killing them. And that all sounds really scary and really daunting. But the LGBTQ stuff kind of like fell in my lap. And I'm really happy, because I do truly feel that the LGBTQ community is a medically vulnerable community for the reasons that we discussed earlier. So I'm really happy that I can have a hand in addressing that in our community. My focus now is to shift back to the maternal mortality piece. What can I do? What kind of program can I create that people are going to want to engage in, where we can make a difference on that personal level? I'm really a big fan of doulas. I'm really a big fan of mentorship style programs. So I'm really hoping that I can kind of marry those two, to kind of, it's about creating relationships between women, to help them, to have that kind of community and that person that they can trust, ask questions to. And so that's my goal over the next couple of years, to really, really kind of push that and kind of build that program within our organization. I've already engaged a lot of doulas in the community who are really, familiar with what we're doing, and have given me a lot of really, really great feedback about the experience of Black women navigating the system. So hopefully in combination with these doulas and women in the community, we can kind of come up with a program, and then I can hopefully get it funded. So that's going to be my goal.
That sounds great. And you're already doing the work. You've reaching out to more than one or two individuals that are from the, Black and brown community. So yeah, that's what I mean, like being intentional. So
yes,
though you have a level of expertise that I know is like phenomenal, but and asking others, for their opinion. That's what you want. I think that's what makes a great leader. I think that's what's going to make your organization stand 10 toes high, because you're taking the time to make sure that you're not necessarily checking off the boxes, but you're being intentional and you're gathering the thoughts and the opinions of these individuals that are working with the population that you're trying to service.
Yeah, I mean, I recognize the level of privilege that I have, and that's the educational privilege. And then also like the society, I mean, I have connections in the community that can work to get this done. So, I guess this is my way of using that privilege that I have, to, I don't know, to put it to a cause that's like bigger than all of us individually. So yeah, intentional is yes. I always, I'm happy to have a team of people around me who will check me when it's needed. And I am grateful to whoever and whatever taught me that, like, that's like, my ego is not nearly as important as that. So I have a good team of people.
That is great. Dr. Marten, I appreciate you coming on here today, taking time out of your busy schedule, as I know you are very busy. But anybody that is watching and you just want to reach out to Dr. Marten, you can go follow all of their social medias, which is the Toledo page, the Solace Health and Wellness. Please reach out to her. She has a lot of resources that will be beneficial. I just thank you for taking time out of your day. I am looking forward to having your organization come to the Scott Center's Community Blood Drive on September 16th at L. Hollingworth. Talented and Gifted. We are doing the blood drive from 9 to 2. There's going to be a lot of community resources. So if you are in the Toledo area, please stop by. Stop by Dr. Marten's table. They're going to have information there along with quite a few other, I think we have well over 10 vendors that's going to have great information. Community resources. I'm all about community resources and collaborative efforts. So, and that's, I heard from you, a lot of collaboration. It is not my intention to work in silos. So if I know someone who has the same mission, absolutely. But this is recorded, so you can share this to your page as well, Dr. Marten. And anybody that's coming in last minute, you can go back and watch it from the beginning. We appreciate you. We appreciate you guys. And on September 3rd, my oldest son, will be on here hosting it all by himself. He's going to give you his perspective as a sibling of two, as an older sibling of two sickle cell warriors, and what that looks like for him. So a day in the life that he has to be a big brother, and just, give his perspective of his lens on what he deals with and how he manages. So I think that will be a great segue into Sickle Cell Awareness Month, which is the entire month of September. So that will take place on September 3rd at 2 p.m. And I hope that you guys will enjoy. And thank you again, Dr. Marten, for coming in and letting my guests get to meet you.
Yes, thank you for having me. I appreciate you too, Sharday.